Nick Majerison here, welcome to Top Med Talk, and today's Top Med Talk is the Q&A session from the presentation made by Mike Grocott, Professor of Anaesthesia and Critical Care Medicine at the University of Southampton. He's in conversation with our Editor-in-Chief, Monty Mythen, and this of course was recorded at the recent Evidence Based Perioperative Medicine, that's EBPOM USA conference. Have a listen.
Top Med Talk. Mike, thank you very much indeed. So I said at the beginning that I wouldn't do all the introduction about you right at the front end of it. So I'm going to explore a few things that you've done in the rest of your career. And one of them I'm going to go to straight away, which I know you always find a little bit embarrassing, is the fact that you have summited Mount Everest. And
which has got nothing to do with shared decision making.
We'll come back to that in a second. Well, there's quite a lot of shared decision making went on in that process. And you took a team to the summit, and you took arterial blood gases close to the summit, and you published those in the New England Journal of Medicine, and you facilitated 500 people going to Everest Base Camp across the years to be tested the effects of hypoxia. Anything that we can learn about leadership that we can translate through? Because, I mean, when you led it as an anaesthetist, part of your summit team was a surgeon, a general practitioner. Any top tips?
Good question. One that I wasn't prepared for. I mean, I guess, so I have a very simple view of what's involved in leadership. So, vision, engagement, and then the operationalisation of all that. And the great advantage we had with Everest, which sometimes makes things a bit simpler, is that we had a very clear vision of what we wanted to do. It was a nicely defined project, which was around the summit and the research we wanted to do. The divisions between surgeons, doctors, medical students, scientists were relatively irrelevant in that context, not for specific roles, but in the overall activity. And I think sometimes in healthcare, I guess, we get a bit confused about hierarchies and status and forget that there's a goal, which is doing the right thing for the patient. There's also a goal which is making sure that you've got to pay the rent within the institution, otherwise the institution fails and you're not there to do the right thing. But there is a goal which is a shared goal, and sometimes it doesn't matter who's leading as long as you're leading to the same place.
Now, the link to shared decision-making, which may or may not be over tenuous, is one of the things I often reflect on is when you're high on the mountain, you're roped together. And if one of you is having a bad day at the office, then they could kill all of you, including themselves. Whereas when you all get back to work, anaesthetist, surgeon, nurses, etc., if you're having a bad day at the office, you all get to go home. And the person that goes down is the patient.
Absolutely, yeah. So
in this complex area of shared decision-making, how do we get the personal bias out of the system? Because whether we run a pre-assessment clinic or do the PASS clinic or with a surgeon, we are inherently biased. We don't often give enough time to truly explain risk and choices in forks in the road. Do we need to get some independence in that space?
I think we do. I mean, I think we're clearly biased. We're also massively limited by the way we work in silos. And I think one of the things underpinning the whole shared decision-making story, and a lot of the other issues we'll talk about, is it's the fact we don't pull together towards that common goal. We have our separate M&M meetings, we have separate approaches to everything, and actually what we need to be focusing on is the patient pathway. What we typically focus on is our patch, either our temporal patch or our physical patch. And we have tended not to structure our teams or our operations or our organisations in a way that actually does focus on the patient pathway.
So now, we both work in the National Health Service, but we've had exposure to international healthcare systems and spend time at Duke, for example. One of the things the NHS is accused of is having death panels. Do you think we have any death panels?
We do not have death panels.
Okay.
We have some sensationalist newspapers that like to paint the fact that we have death panels.
So access to surgery, irrespective of all the factors that one might consider, you're not denied surgical procedures because you're just old, for example, or...
You're not. We have elements of there are changes coming whereby wholly ineffective surgical procedures are going to be harder to get, but they're not going to be completely denied if there's evidence that that procedure will help you. So things like tonsillectomy, grommets, where the evidence base for any benefit is very thin, if not absent, will not be as financially incentivized as other approaches.
But we do seem to put quite a lot of effort, because we are essentially close to being an ACO, a single payer provider system. We put quite a lot of effort in empowering the patient to decide not to have surgery, to give them enough time. And the evidence suggests that when plenty of effort is put into that, a fully informed patient chooses to have surgery less often than a non-fully informed patient.
The better informed they are, in general, the less likely they are to have surgery. So there's an evidence base around decision aids, which suggests if you leave the doctor at it, you simply put them in front of a screen, allow them to put their own data in and look at the stats, patients are less likely to have operations, and certainly if they have an informed conversation, they're less likely.
Because we recorded a very interesting interview, Desiree led it, a roundtable discussion with a lead orthopedic surgeon from the United States of America and the president of the AARP, the American Association of Retired People, I think it is. And he was very, very adamant that we don't spend enough time, and it's a quote that comes from elsewhere, asking patients what matters to them. What we tend to ask them is what's the matter? In other words, why have you come to me? I've come here because my knee hurts. And what we should go on to say is, I know your knee hurts, but what would you like to do if your knee hurt less? And the example he gave was to say, I'd like to be able to dance at my daughter's wedding. And once you've got that understanding, you know, if the aim is knee replacement, for example, is the only way to allow him to dance at his daughter's wedding, if that's a fully informed decision, there's a marginal chance that he'll have less pain from a knee replacement, and there's a much, much greater chance that he will have a stroke or an MI, according to the only randomized controlled trial, compared to making a decision whereby he takes orthotics and exercise and PT.
Physiotherapy, etc. Yeah.
So if you then look at the gamble, there's a marginal chance that you'll get less pain, but there's a very real chance that you might have a stroke. And then they might turn around and say, I'd rather have the orthotics and the exercise and adjusted pain meds, because my aim is to dance at my daughter's wedding, not for the pain to go away forever, if the risk is stroke and MI. And he was quite critical of the systems globally, but also in the US.
Couldn't agree more. But we do set up our systems to solve problems. So, you know, patient presents with condition, follows pathway, arrives at surgeon, has operation. And we don't tend to frame them around how can we solve your problem.
Now, in the UK, we have had for a while now long-term follow-up of our joint replacements, with about 70% capture of all joint replacements in the country, whereby patient-reported outcomes have informed us that although the majority of patients' pain improves, 4 out of 10 patients, their overall quality of life after a knee replacement gets no better, and 3 out of 10, their quality of life gets worse. Now, the orthopedic surgeon we'd sat down with said that according to his understanding of the US knowledge of long-term follow-up for joint replacements, not a few weeks, but long term, was by his estimate was 1% of surgeons know their long-term follow-ups, which is an interesting, morally and ethically, that's interesting. So can we get the Slido questions up, please? And can we get a microphone to the person over here who has their hand? It's Lee, I think. We'll just get a microphone to you, Lee, if we could. And then we'll come to you, sir. No.
I commend you for saying starting early, because I think consent or the decision for surgery is a temporal decision that really starts with the family. So by the time they see us, at least in the pre-op clinic, is it fair to put the burden from a shared decision-making perspective? And I'm actually curious, we believe in patient autonomy. Have we gone too far, at least in the US, in saying it's the patient's decision? They come to us as experts. How much should we... Is paternalism always bad?
I don't think paternalism is bad if the patient is seeking that approach. And patients have a broad spectrum. I mean, you talk about this often, Lee, a broad spectrum of desires for their interaction with their physician. some people want to be informed and be very clear that they make their own decision, and some people, and I see this a lot in critical care, they really don't want to know all the details. They just, what would you do, doc? What would you do if it was your mum or your dad or your child? And all those, wherever you sit on that spectrum, that's fine. And clearly, we have more of a role and a different type of responsibility at this end of the spectrum. But I think if the patient desires the autonomy, they have the right to not have whatever they want. They're coming to us. We have no right to tell them what to do. We have an obligation to advise them and help inform them to the best decision in the context of their life.
Tom.
Lee and Sal show. Another interesting perspective, and I think one that's probably more likely to resonate with us in the States right now. We're not single payer. We're not the NHS for sure, at least not in the foreseeable future. Is interestingly what we've experienced is sometimes the surgeon really appreciates some other entity to help them say no. In other words, the burden on a surgeon to operate when there is a recommendation, albeit from the patient or the primary care who thinks that's the pathway to take, they're in a tough spot to say no. It's probably not in your best interest. And so what we've developed at Duke, and it's been really interesting in almost a underappreciated way, is we have a clinic that serves the particular special needs of an elderly population, the POSH clinic. And I would say about 2 to 4% of the patients that they evaluate, these complex elderly, cognitively declined kinds of patients, are actually, after consultation with the family and other extenders in that concentric circle of their world, they help drive the decision that surgery is not in the best interest, and it takes the burden off of the surgeon to have to be the one to say, no, I don't think this is in your right best interest. I just want to make that point and hear your comments on that. And the second comment is that, again, because we're not a single payer, I think in our bundled-based world, our sort of externally driven pressures that are economically upon us, that decision to say no will be made because we can't afford to make the wrong decision. I think there's going to be an economic drive to that.
So I'm going to answer both questions by actually talking about our cardiopulmonary exercise testing service, which is not a lateral move. They're very closely related. So that is our means of, or a central component of our means of stratifying risk. And we've when I moved to Southampton, we went on a journey of implementing through some patients to now almost all patients having major surgery. And it was striking in the some patient stage that a large number of those patients that the surgeons were at that time referring, it's now routine, they were doing exactly as you suggest. So the patients where they just didn't feel very comfortable and they wanted a reason not to, but they did have the particular pathology that needed the surgery, and they were very much, and they would admit this, they were sending them to us in order to have a get out. So I think that's absolutely correct. That's the second part of what you said was
the external force of economic tension to drive that behavior.
So the NHS does not currently function fully as an ACO. It's on the bundled payments spectrum. So we have commissioners who buy care off institutions, and the institution's an independent financial entity. With the cardiopulmonary exercise testing service, we have a shared decision-making model, and one of the things that was overwhelming in the business case was not the more typical things that cardiopulmonary exercise testing is named for in terms of stratification to critical care. It was the fact that we were, for some of our major surgeries, getting a 10 to 15% shared decision not to operate. The shared decision related to the patients, as I described in the presentation, who were at the highest risk. They were making a rational decision based on harm outweighing benefit. They're the ones that are going to have the complications and the long stay, and therefore be a resource strain on the institution. So that the business case was made on the shared decision-making element of cardiopulmonary exercise testing. So I think the economics work.
Mike, just to clarify, in the shared decision-making process, because I remember when I was a young doctor in any system that patients would be told they weren't fit for surgery, for example. The shared decision-making process is is different from the point of view as it lays out the risk of the individual. And if they decide to go ahead with the surgery, despite there being an extremely high chance of death or a poor outcome, they still have the right to pursue that path if it's informed. In other words, if they turn around and say, I understand I've got a 30% chance of dying, but I cannot tolerate this thing and I want it to try and be dealt with. I understand, doc, that I might not get off the ventilator. That's okay.
That's okay.
But that's fully informed.
I mean, as long as the surgeon is happy to go with that.
And everyone's involved is fully informed.
Yeah.
Did you want to come back on that, Saul?
Just another interesting anecdote. We just recently looked at our data from the CGR, the joint replacement program that was in place until Price and the administration currently kind of discontinued that program. Interestingly, of around 8,000 patients that we looked at CGR versus non-CGR hospitals, we looked at bundle busters, if you will, those patients that we were able to do with some margin by virtue of our care redesign, and those patients that we lost money on. Despite our best intent to identify the risk and manage that. And one of the interesting things that we found is that the likelihood, that one of the greatest predictors of the likelihood for a readmission within a 90-day window was whether or not the patient was married or not. Now, that's a surrogate for home care, if you will. So the question then is, should we, this is a rhetoric question, if we're under the pressure of economic sustainability, not be inclined to do a procedure if we think we're going to not be sustainable by doing it unless we know that we can get somebody to a patient's home and visit them every Tuesday or whatever if they're not married? It's an interesting question, but it changes it's an economic variable of what is a right patient for the right surgery or wrong patient for the wrong surgery.
So short answer, no. But I mean, it's a very intriguing question. It plays to the prehabilitation agenda and the notion of rationing, which, if you don't do your exercise or if you don't give up smoking, will we withhold surgery? That's not actually what's going on in the UK, but there is a considerable amount of transactional behaviour between doctor and patients where they say, look, if we pause the clock here and you do give up smoking, it will go better. So how about do you want to do that or do you not want to do that? Which is very different from we're going to ration. Now, it's a little bit difficult to stop the clock and get people to get married, so I'm not quite sure where we're going to go with that. But I mean, I think individuals who we know are going to have a challenging post-operative recovery, and including post-hospital recovery because of their social circumstances, then we probably need to set up the social support. If we're going to be fully frank and honest, we probably need to share that with them as part of the discussion about risks of surgery, risk of readmission.
So before I come to the next question, and maybe this needs to go back to Sol for a second, one of the challenges with informed decision-making is if you look at the literature, as I said, there's a reasonable chance that you'll be doing 10 to 15% fewer surgeries on that cohort of patients who go through it based on their own fully informed choice. So if you're in the business of doing surgery, you've just knocked your productivity by 15%. So who's going to fund doing the right thing?
Just jump out. You may not have knocked your productivity. You may not
no, sorry, expressed wrong.
You may improve your productivity.
Depending on the funding system. If you're fee for service, then business is business. If you're bundled, then it's a different equation. So where's that come from, Sol? How do you?
It's a great point, and I think it really underscores the whole philosophic foundation of this discussion, which is we're in a transition point in our healthcare system in this country, for sure. Maybe defined a little bit upstream to what you've already experienced in the UK. But we have to behave differently as we drive toward population health science. And so the question of what was the definition of value yesterday is going to be answered very differently tomorrow. And so more surgery may not enhance value.
I mean, there are a number of, as an institution, you manage your medical legal risks much better if you don't do surgery on people where harm outweighs benefit.
And a bad choice of words, Mike, because productivity actually goes up, doesn't it? Because you get throughput is better. Tim?
I think it's very interesting when you think about this question overall to look at what we do. And there's a very interesting book, How Doctors Die, that basically says that when we're looking after ourselves or our loved ones, we have a very different approach to often a lot of patients, and we're much less aggressive, particularly in long intensive care stays, being in hospital in general. And I think we're the ultimate informed patients, and I think we would have very different approaches to our 85-year-old mother who may need a Whipple, and we're much more likely to realise that after a Whipple the life expectancy is only 9 months, and that may be the wrong thing to do. Do you know if anyone has looked at that? Because that's an interesting model for the ultimate shared decision-making.
So, I mean, the literature you cite is consistent. So if you ask oncologists about cancer care, they are much more conservative in regard of their own health than they would be in regard of their patient's health. So given the same scenario, they're more likely to recommend a particular type of chemotherapy, for example, for their patients. In a way, that's the fundamental message to all of this, because as providers, it's easy to feel a bit paternalistic. But if you just flip it round and go, so what if it was me, what would I want? I would want all the information and a very good explanation and maybe a second opinion, because I don't want to make what's going to be a very, very important decision in my life. I don't want to make a wrong decision. And that's what we should be offering to our patients.
Monty Grocott, I'm from New Jersey, anesthesiologist, and my question relates to time. That when it's a shared decision making, you need to have an empowered patient who is obviously very educated before, and physicians have a very significant time constraint in their hand. My question is, where do you see the role of perhaps technology? We use intensively technology to educate these patients. Perhaps also some type of visual help aid in the decision making, so they already separated the two things, educated, and when they make the decision. In the meantime, perhaps another important part of it is not just the patient, it's the patient's family, so they have a chance to discuss it. I'm wondering where do you feel that?
So I think that you are undoubtedly correct that you can help for some patients, you can help that decision-making by providing sophisticated decision support. And that would, like I'm sure for anybody in this room, that would work really well, and you can pore over the graphs and the figures, and that will inform your decision. For a substantial proportion of patients, for a variety of different reasons, they might choose not to engage with the world in that way, or they might be unable to. That's not the answer. And actually the fundamental core of it, I think, is the conversation. Because the conversation has to establish where they sit on the spectrum. Do they want to decide, or do they want you to decide? And then the communication, I mean, there's a reasonable amount of technical literature about how to do shared decision-making, and the communication of harms and benefits in the same way and in a way that is understandable. So not risk ratios or odds ratios, but, how many people, 3 in 100, 3 in 10, one person in a village, one person in a town, and commuting everything the same way. And even, say, positive risks, negative risks, 95% of people survive as opposed to 5 people die, is received differently. And if you present the harms in one way and the benefits in another, people are, even we, when are unable to weigh those things correctly. So a lot of it is about very precise but simple communication of risk in a consistent manner between both benefit and harm.
So I've got some questions to the floor, but I'm going to just knock off the most popular Slido questions quickly, Mike. So pithy answers are fine. Who should lead the shared decision-making conversation? Surgeons, anaesthesiologists, primary care?
It's going to be, at the moment, it's going to be about who wants to do that and who is naturally coming to the fore doing it. And I think, it's a bit like enhanced recovery. Anaesthesiologists led the team, surgeons led the team, sometimes non-physicians led the team. I don't think it matters as long as they are appropriately informed.
But it's emerging as subspecialist skill, really, isn't it? It's not every provider is good at it, and you need training.
You do need training, and I think anaesthesiologists, I think it's almost helpful to the surgeons to have the anaesthesiologists leading it. They can be a protagonist, and if you like, the anaesthesiologist can provide the balance.
Do you think ideally shared decision-making should be an MDT meeting with the patient, anaesthesiologists, etc.?
I'm not sure if that's all right. So the MDT meetings that I go to, which are relatively infrequent, but there are large numbers of people, lots of cases, lots of information. They're very technical and efficient, but they're not an environment that I want to make a life-changing decision in. So I think the MDT can gather the information to inform the conversation, but you really want the conversation to be a one-to-one or someone talking to a person and their loved one.
Because I've watched some of the videos of shared decision-making, exemplar shared decision-making, and remarkably skillful in not loading the bases one way or the other. They definitely don't. They present the information and the statistics and the pros and the cons and the forks in the road, but they don't nudge people down one fork or the other, as the MDT personalities tend to come to the fore and start to lobby for a particular approach.
And it's probably a little bit harder to have the full and frank discussion that the medical professionals want to have about quickly and efficiently. So I think the MDT is great for information gathering, but the discussion should be, and the discussion needs more time.
So last slide, everyone. I'm going to take the one at the top there. I'm going to think we've just answered. Should you direct a patient away from a provider with known poor outcomes? Ethically, should you? Professionally, can you?
So I think the answer is self-evident.
Well, tell us.
I don't think
tired now.
I don't think you should be. If you truly think that a provider has poor outcomes, you should not be directing a patient there. If that's that clear. And I don't think there's any professional conflict at all there.
So I think you're saying is you shouldn't divert a patient away from a poor provider, but you should not point a patient at a poor provider.
I certainly wouldn't point them at a poor provider, and if you had any power over the decision, you might try and divert them.
And nationally, we have a system to deal with that, don't we? We have open. You can look every surgeon up in the country, and they have where they are on the grade of from the point of view of whether they're within the bounds of acceptable, satisfactory there.
You can, although I suspect that the surgeon within their team, the differences are relatively subtle. It's the institutional wrapper which is much more important.
Much more thing. Sorry, sir, I think you've got the microphone over there, please.
Thank you. My name is Stefan Esper. I'm from UPMC in University of Pittsburgh. I just have two comments I'd like to make and then a subsequent opinion back from you if appropriate. I think one of the issues that we've seen in our institution, I'm the director of the Enhanced Recovery Programs, along with one of our surgeons who's going to be here too, for the system. One of the issues that we've seen, especially in these patients who are 88, and there was a 94-year-old girl who walked into my clinic who needed a complete reconstruction, and she was referred from the oncologist, said, you need surgery. And I think one of the issues that I've seen with a paternalistic approach is that the individuals who practice within the medical field on the internal medicine side from those specialties don't actually see the post-operative outcomes the way we see them in the hospital, because we've seen those patients really respectfully go through hell and not really come out of that on the other side, along with their families. And so I think that would speak to the initial question of who should be directing that conversation. In my estimation, it's an individual who straddles both the surgical arena, who sees those post-operative outcomes, and the medical arena, who is able to understand what these patients require. And obviously your comments on that. And then the second thing, the question of who should actually pay for this, because it is true, one of the issues we're facing in our hospital system, in our clinic, we've actually ended up referring 20% of patients to non-operative therapy. The hospital isn't generating revenue from those patients coming in. Who should pay for that? I happen to work for an integrated delivery and financial healthcare system. And so I think that the health plan, the insurance companies who are looking in terms of improving healthcare, you improve outcomes, or improve outcomes, you improve healthcare. I think that they should have a role in paying for that, and I'd like to hear your comments on that.
So I agree on the who should pay piece. I mean, clearly there can be tensions if your shared decision-making has resulted in an acute fall in throughput for particular surgeons or particular services. That is going to be challenging, but in many ways that's a symptom of a problem with the system rather than a problem with what to do with the patients. And what you say about physician referrals is also very familiar in the world I work in. I mean, I think you're leaving a hostage to fortune always if you refer someone without saying, I am referring you for advice and the possibility of, as opposed to this person is going to do this thing, because they're going to make a professional judgment, and it's likely that they know more about their specialist area than you do, otherwise you wouldn't be referring them. But I hear what you say. I mean, it's challenging. The shared decision making, not only the skills as anesthesiologists that we need to have, some slightly additional comment, are not only around the communication of risk, but there's also an awful lot around prognosis. So we're used to the risk scores and what the deal is if you've got heart failure or atrial fibrillation, but we need to learn a lot more about their worlds. So life expectancy following procedure A, B, C, chemotherapy, immunotherapy, immuno and chemo, radio. The perioperative physician role is going to be more complex in that regard, and we will have to skill up in terms of our knowledge of the different prognostic pathways.
I think tied in with Stefan's question there and touched on in one of the questions down here is the suggestion that shared decision making is in some way motivated by the objective of reducing the cost of care. But I think I'm right in saying that wrong patient, wrong surgery is the most expensive care you can deliver.
Yeah, economically it should pay for itself. It certainly does in our institution. I mean, it's the right thing to do for a patient. That's the overriding reason to do it. Yeah. But sometimes that's also really expensive, and therefore you have a cost-benefit discussion. I don't think there's a major cost-benefit discussion here, because not only is it the right thing for the patient, but by the way, you're likely to save money.
Hello, I'm Jake Thomas. I'm from Iowa. You glossed over a little bit about the communication required to do shared decision-making sort of fairly and openly so as not to induce bias. But my question, I guess, is, should we, as gatekeepers to fabulously expensive healthcare resources, behavioral economics have taught us that this kind of communication, this kind of decision-making process is almost like a superpower. By focusing on certain things versus others, we can ensure that people who are likely to be our costliest customers, likely to have bad outcomes, don't end up choosing to have surgery. Is there some role for the anesthesiologist to be a gatekeeper for these kinds of very high risk, very poor outcome patients to prevent people from hurting themselves?
I mean, I think that's part of what it's about, because I would be surprised if there are many people in this room who haven't had the experience of seeing someone go through surgery and it's just not going well, and almost everybody in the room, sometimes everybody in the room, is thinking, why are we doing this? And yet the journey on the way there seemed all perfectly rational, because A followed B, followed A, and C followed B. So yes, I think we do have a role. Framing it as a gatekeeper, I think, is difficult, because the economic argument is not the overriding argument, I don't think. The economic argument is mutually supportive of doing the right thing, but actually it's about doing the right thing for the patient in their particular context, as we've touched on before.
So, Mike, in closing, I'm going to rattle just a few of these off. Do you think surgeons are becoming more aware about the need for shared decision-making?
Yes.
Okay. Speaking of silos, what can an institution do to overcome the problem?
Much more challenging question. I mean, it's about rewiring the whole institution. It's about changing hierarchies. It's about changing who's meeting who when to make decisions. And and I think it's happening, but it's happening in part because of management, and in part because the younger surgeons and the younger anesthesiologists just are learning to behave in different ways.
I'm going to go down to the CPET one for a second. Do you have to do CPET to guide your risk assessment and in turn discussions of SDM? So it's not.
Say that again.
So do you can see it on the slide there. Do you have to do the CPET to guide your risk assessment?
No. So Michael Swart, who's a good friend and one of the very, very early initiators of cardiopulmonary exercise testing in the UK, who is still a huge fan of cardiopulmonary exercise testing, actually says if I was whittled down, I had less and less time and less resource, actually the shared decision-making is the fundamental piece, and the CPET and the various other tests and everything else, they feed into it. But the most important bit is the basic physician-patient interaction and the shared decision-making.
I'm going to jump to Erica's question. Hi, Erica. Would it not be better to form a multidisciplinary team to review difficult patients, much like a tumour board, and have a consensus to bring back to the patient, which is...
So what we do, so we have multidisciplinary team meetings, but they can then inform, so that the meeting can come to a particular view, but that view may not be correct in that patient's life. They may not want to take on the risk of a 5% mortality risk in the next month, because they may have a very significant life event in 3 months' time. They may have a particular view about specific types of complications, based on their profession or their hobbies or anything else. So I don't think it's possible for a team to tell a patient what to do unless the patient actually asks them to. You can provide them with a menu of possible outcomes and some relative harms and benefits, but telling people what to do, I get very nervous of.
So I apologise we haven't got time to do just the last two, but thank you very much indeed, Professor Mike Grocott.
Thank you.
Top Med Talk. So if you enjoyed that piece, you will notice that some of the questions were sent in from the audience. No, not the audience in attendance at the event, but actually the audience who were listening online. How do I do that, Nick? I'll tell you. You get yourself to topmedtalk.com and then you click on the live stream and you can listen to us as and when we're broadcasting live from the conferences that we attend. But how would I know when they were on, Nick? That's the next question you're asking. Simple. Get yourself to the website and sign up for the email updates. Once you've done that, you'll get all of the vital information regarding your favourite medical podcast as and when we can send you it. So you'll be able to know where we are, how you can meet us, and how you can listen online. Make sure you sign up for regular email updates. Also, of course, don't forget to subscribe to the podcast, find us on social media, and finally, check out the EBPOM website, ebpom.org/meetings, to find out more about some of the conferences that we will be in attendance at. That's ebpom.org/meetings.